Good morning, everyone. It's a great honor for me to share our experience with all of you. Thank you for the chairman for the introduction. We would like to share about our experience in complex double outlet right ventricle repair. So this is my hospital, placed in the central Jakarta. So we did 1,400 cases a year. We start the program for pediatric only on the 1985. And we have 3 OT currently with 6 pediatric dedicated cardiac surgeon. And also we have the 20 ICU beds. This is our room, placed on the 8th floor of the building. We can see the sunset over there. And this is our current, like Professor Fak showed that we also consider mostly on the VSD location and also relation with the great artery, and also consider about the pulmonary stenosis. So now we would like to share about our experience in this particular difficult case. So we do hope that we can do about ventricular repair instead of pursue the single ventricle tract pathway. So why I say we have limited resources? Because we do lack of the 3D images data and no 3D printed heart program currently. And unfortunately, we do the big problem because of the limited funding. So we have to figure out how to overcome the long queue patient, especially for difficult cases, 18 months more for complex cases. So we have to do sometimes delaying the decision in order to gain more procedure for all our patients. And no ECMO, it's too expensive. We can do 3 or 4 tetralogy of valve repair instead 1 ECMO patient. So we would like to share the first case. It's a double outlet right ventricle, non-committed VSD, PDA, mild coarctation. I did the PA band on 3 years ago. So I did the complex double outlet just 1 week ago before this event. So this is the X-ray. I compare, this show that this is initially the 3 years ago's echo. We saw that huge VSD, but non-committed with the great artery. Nowadays, it's closer to the pulmonary artery, huge pulmonary artery. 4 chamber. There is a conus or subaortic muscle over here, and we cannot see the pulmonary valve. It's very huge VSD, and also, as you can see here, huge VSD, inlet VSD. Unobstructed the aorta, and loose PA band. Gradient across the PA band is 30. Malpose great artery, almost side by side. Yeah, this is huge conus muscle. And for the coarctation itself, only 12, so just ignore it. We did the CAT study. It getting worse than before. The resistance index previously 6, nowadays 7. So in the OR, I found there is a PDA still there. Limited 3D CT, seen that the VSD closer to the pulmonary artery rather than the aorta. So the procedure itself take 151 cross-clamp time and CBB time 210. I did several procedures over there, including arterial switch operation, intraventricular tunneling, subaortic conus resection, tricuspid. The tricuspid, in the anterior tricuspid, there is a huge deficiency. So, and also I have to do the ASD creation just to avoid pulmonary hypertension or the poor RV function.
This patient is 4 years old, diagnosed with DORV, non-committed VSD. Previously underwent PA ban 3 years ago. Yeah, this is after a careful additionalysis. Now I would like to do the PA debanding. Previous ban looks good, and there is also PDA. I did a PDA ligation. I did the standard bicaval cannulation, and after cross clamp, so we have to test the tricuspid. We can see there is a defect, yeah, a hole at the anterior leaflet of the tricuspid here, yeah, huge hole there, yeah, and from tricuspid we are also able to see the aortic valve, yeah, but not so clear, so we have to resect the tricuspid as well as the muscle, yeah. As we can see from the previous echo, yeah, this muscle is underneath the annulus of the aorta, so I did the resection over there. So now we can clearly see the VSD over here, yeah, and also huge VSD, and also far away over there I can see the aorta but not so clear, so I have to do the aortotomy, yeah, and then try to figure out the relation between the VSD and the native aorta by using Hagar dilator, like this. So from the tricuspid I can see that this left ventricle, the outflow tract to the aorta, it's far from the VSD. So underneath the aorta is the main pulmonary artery, and then to make sure of this, I have to do the MPotomy. Here I need to cut out the main pulmonary artery, and also by using the Hagar dilator I can see the VSD is close to the main pulmonary artery, so the plan is to do the arterial switch later. But now first of all I have to do the VSD closure first, intraventricular tunneling, by using the big and long PTFE patch, 0.4 millimeter. Yeah, I have to create the unobstructed tunneling, yeah, by using this patch, and using continuous suture of polypropylene 5O. Yeah, and then I can, yeah, so here this is almost finished, the patch. As you can see, it's huge, but it's not finished all. It's only the inlet part. The outlet part I have to close the VSD through the main pulmonary artery here. So through the main pulmonary artery I close the VSD, same stitch, 5O polypropylene round bodied, and for the upper part it's very close to the pulmonary annulus. Yeah, yeah, it's almost finished. Yeah, we can see here this is the pulmonary valve. It's very close to the stitch. Yeah, I have to put the plate over there just to make sure it will be strong in holding this stitch. And then after VSD closure, I have to do a little bit annuloplasty on the tricuspid valve by using plated suture, braided ethibond, yeah. So the defect of the tricuspid will be close each other. And then here I combine it with the commissuroplasty between the anterior leaflet that has defect, yeah. So it will close the defect by using also the same 5-0 prolene, yeah. And then I test it with saline. Here I test the function of the tricuspid valve with the saline. It's look pretty good, yeah. And then I prepare to do the arterial switch. First of all, I have to figure out the course of the coronary artery and then harvesting the coronary artery button. And then start to transfer the left main ostium by using trapdoor technique on the proper part of the neo aorta or previously main pulmonary artery. Using trapdoor technique. Yeah, I don't have any difficulty because I relieve all the possible way just to make free ostium of the left main. Yeah, almost finished. Yeah. Yeah. Now I start to transfer the RCA button also with the same technique, trapdoor. Yeah, this is the RCA implanted to the neo aorta. After that, I will anastomose. Yeah, this is finished, the coronary, and then continue by anastomosing the neo aorta to the ascending aorta. Using now, I use the 6-0 long needle polypropylene. Yeah, almost done. Connecting the neo aorta with the ascending aorta. Yeah, almost done. Now, using the treated autologous pericardium, I reconstruct the root of the neo pulmonal, yeah, previously aorta. Yeah, same with 6-0. Monofilament. Yeah, it's almost finished. Yeah, I have to do it on the cross clamp just to optimize good anastomosis, no bleeder, yeah, and well constructed. And then I resuspend the commissure of the neopulmonal, yeah, to the autologous pericardial patch, and then followed by the anastomosing the neopulmonal to the main pulmonary artery, yeah, on heart beating. Yeah, it looks heart so happy now, almost finished. I left the small ASD just to prevent or anticipate the pulmonary hypertension. Yeah. Yes. Now this is the heart look like after decannulation. Yeah. Minimal inotrope, and the hemodynamic looks promising. It's very good. We'll see the echo after this.
And then this is a post-op echo. We can see here the outflow tracks very well, good, and also there is no mitral or tricuspid regurgitation and good biventricular function. And the LVOT gradient only 6 millimeter mercury, RVOT gradient 24. So this is patient, require ventilator time 26 hours and ICU stay 2 days and discharged from hospital for 7 days. And the second one, yeah, is the double outlet, also non-committed VSD, underwent PA ban 4 years ago. Yeah, we did also the biventricular repair. This one with the double patch technique. This is compared from the previous X-ray. Nowadays, the heart very good, smaller. But as we can see here, huge VSD, but we cannot see the great artery. Still, until now, we cannot see the great artery remote. See, this is the inlet VSD before, and no obstruction underneath the pulmonary or aorta. But recently, after 4 years, we can see here the RV develop thickening. Yeah. So the VSD very far from the aorta and also the pulmonary artery, and also there is a muscle over there. And also create the RVOT obstruction. Compared to before, yeah, it's a huge obstruction. Maybe because already too long, 4 years. I did the biventricular repair, intraventricular tunneling, subaortic conus resection, required cross clamp 95. But after surgery, patient running well, ventilator time only 18 hours and discharged after 8 days due to the junctional rhythm, but it's converted to sinus rhythm after day 6. I have to excise the tricuspid valve in order to visualize and also figure out how to create the patch. So as we can see here, there is a conus muscle, and also this is the aortic valve over here. And I have to resect the RVOT obstruction as well as the outlet septum muscle. And then created 2 patch. First, I put a patch using the 10 millimeter PTFE, divided, and create a unique shape, and then followed by the second patch, also using the 10 millimeter PTFE. So it will create the non-obstructed pathway from the VSD to the aorta. This is a patient, put a MPA patch after PA bending, and good hemodynamic. And this is post-op echo, as we can see here from the LV to the aorta, a bit stenosis, but the gradient not significant, only 7 millimeter mercury, and RVOT also wide. And this patient, he's afraid of me, so getting cry. But I'm happy because the patient is so well and very active. Okay, I have 2 more minutes, but this one I can move forward because this one is double outlet right ventricle with subpulmonic VSD, but severe pulmonary stenosis. Yeah, just a second, like this. So this pulmonary artery is very small, and it's not possible to be the neo aorta. So we have to figure out best decision, because for pulmonary artery is very small, but huge aortic annulus, and the patient has balanced ventricle, we should avoid the single ventricle tract. So we did the Nikaido without explanting the coronary artery, explant the aortic root, but still keep the coronary artery. And then this is a main pulmonary artery, excise the pulmonary valve. This is the left coronary artery. I will proceed. Okay, and then bringing downward the aortic root to the new position, and then put the intraventricular tunneling from the VSD to the new aorta. And then on beating heart, implant the contigra. This is after surgery. The hemodynamic also good. Okay. And this is after surgery, the LV to aorta good. Also the pulmonary, there is no pulmonary stenosis, significant pulmonary stenosis. So, and for the Indonesia, we have 270 population and only 18 dedicated congenital heart surgeon. So this is the double outlet right ventricle for last 10 years. There is 931 cases, and mostly it's a doubly committed VSD, but these two, 44% with non-committed and unspecified. The biventricular repair we still in learning curve, but we try to delay in order to avoid the single ventricle tract. The mortality is reasonable. So for summary, if we find the double outlet right ventricle with good ventricle and IV valve, but non-committed VSD without PS, see, it's always possible. We prefer to delay a bit and then figure out later the biventricular repair. So we suggest for the stage repair to increase the chance of biventricular repair. Thank you.
Thank you. Thank you, Dr. Budi.